you everyone for being with us this afternoon. The Value and Innovation Forum is proud to present the What are Z codes and how do they impact health equity? First, I want to recognize the Value and Innovation Forum. It's a collaboration of the National Forum for Heart Disease and Stroke Prevention, as well as the Patient Advocate Foundation, of which I'm the CEO. We're both 501c3 nonprofit organizations. The topics for the briefings are selected by our steering committee, of which National Forum and Patient Advocate Foundation are a part, alongside of the Alliance of Community Health Plans, the Association of Black Cardiologists, the Caregiver Action Network, and the National Osteoporosis Foundation. These briefings are made possible by funding from Amgen in accordance with the National Forum's policy on corporate and foundation support and relationships. So what we're gonna, next slide if you don't mind. So we've got an interesting program for you today. The purpose is to, what it sounds like, give you an introduction to the Z code world, how it relates to health equity and social determinants of health. We will have an opportunity for Q&A, so please use that Q&A feature for any questions you have. We do have in the agenda about 3:40 to 3:45, in that range. We'll explicitly begin to take the questions off the Q&A. I'll be monitoring it, as will the speakers, but primarily myself, and may answer those questions as they come in, and some I'll tee up for when we get to the audience Q&A. So don't be shy about using that Q&A feature as we go, but most of those questions I will field to the panelists when we get to the Q&A portion. There's the speaker introductions. Just very briefly, Julia is the Senior Program Manager for Strategic Initiatives at the American Hospital Association, and part of her work, she leads the organization's work on social determinants of health. And then we also have Katie Sollenberger, who is the Epic Site Specialist at the Rhinehart Clinic and works to develop workflows around social determinants and health screenings and data tracking. There's more to their bios, but in the interest of time, we will jump in. I'm going to just do a quick set of slides to level set around Z codes, and then we'll start a conversation with our two speakers. So Z codes are a special group of codes provided in the ICD-10 framework for reporting factors influencing health status and contact with health services. Specifically, we're going to focus in on ICD codes Z55 to Z65, because those are related for persons with potential health hazards related to socioeconomic and psychological circumstances. So if you're wondering what that means, here you go. Next slide. These are those Z codes. And if you're familiar with ICD-10 codes, they start sort of at that higher level, and then they get numbers down to the tenths and the hundredths and even the thousandths with more specificity. So these are the 10 general Z codes related to social determinants of health. Even within this, we're going to focus a little bit on specific ones. I'm not going to read these to you, but you get the idea if you take a quick glance at these. Z59, for example, problems related to housing and economic circumstances. You have some psychosocial areas, but basically these are ways to, at a high level, capture a set of issues related to what we traditionally think of as social determinants or health equity type of factors: employment, transportation, food, insecurity, etc. Next slide. So I'm not going to read this to you, but just to give you a sense that this is serious. This is a CMS infographic about how to use Z codes. I'm not going to go across the spectrum here, but they do anticipate a pretty wide and comprehensive use of these, everything from collecting data to tracking the data, to mapping data, to actually using the data for quality initiatives and data reporting. So there is, it's not there yet, but there is an anticipation and an ambition on the part of CMS and others to really use this Z code process in a pretty comprehensive way at the clinic level, including using it to map referrals to community organizations, etc. We're going to send you these slides, so if you're really interested, you can take a look at this or even link to these infographics from CMS directly. Next slide. And they also have obviously divide up the Z code and its potential uses around the healthcare team, healthcare administrators and coding professionals. The point here is not to read all this to you, but to tell you this is serious, and it is something that is anticipated to broadly be used in the healthcare system at numerous levels and across the care continuum. Next slide. So more recently, there's been some efforts to try to expand the Z code. So there are officially those 10 codes recognized in the ICD-10 platform. There is a coordination and maintenance committee that determines these things and decides what codes will be formalized into the ICD platform. In the March 2019 meeting, there was a proposal made by United Healthcare and the American Medical Association to add over 20 new Z codes under the existing social determinants health categories, which are those 10 that I have already showed you. There was an additional proposal from Blue Cross Blue Shield of Vermont and Yale School of Nursing to specify within a particular Z code around food insecurity. I'm not going to show you those. The purpose is to let you know there's interest in expanding this, and it's coming out of a lot of the payer environment as well as the healthcare setting as well. The rationale for these proposals were to increase the granularity of tracking the various social determinants of one's health. So I'll give you an example of what that means, but basically breaking down those Z codes into point, the tenths and the hundreds. So 55 point whatever, 55, 56 point something, and I'll show you what that means. But it really then begins to take that larger code and be able to even further sort of qualify a particular patient with a subset of a diagnosis. And I just to let you know, the American Health Information Management Association, I didn't pick them for any other reason, but just to give you some sense of the feedback, they actually, in response to those proposals, recommended that the approval of those codes be delayed until the work of the Gravity project is completed, because that's a project where they're actually, it's a national collaborative launched by the Social Innovations Research and Evaluation Network to advance interoperable social risk and protective factors documentation. That's only, if you're curious, that's a place where you can go if you want to be more engaged. That is one collaborative framework in which groups are trying to look at this and be influential in how to shape this Z code environment. So next slide. Another, just to give you a sense of who else is active in this space, and there's several, but I'm just highlighting one for you, not for any particular reason, just to illustrate the point that this is something that is being rolled out and taken seriously at the payer level and at the hospital level and the clinic level. Recently, Kaiser Permanente announced that they'll be rolling out a plan called Thrive Local, and they may have already done this, so sorry if it's past tense and it should be present tense, to track and address social determinants. And there was an article in Modern Healthcare that says a number of hospitals and health systems in recent years have begun to incorporate patient social needs within their EHR systems or HER systems to aid clinicians in identifying the root cause of health problems. And some have even modified their systems to help connect their patients to community resources. And I believe we've got some examples of that for you this afternoon. So next slide. Sorry, go back. And we'll, that's it for my introduction. And what we can do is jump into our panel discussion. So I'm going to kick us off here with Katie. What I'm going to do, just for the audience, I'm going to just ask a question of both of them, and they're going to take turns answering the question. I may pose a follow-up if need be, but again, the point here is to be pretty high level and be introductory. I'll start with a very high level and introductory question for both of our panelists. How and why is your organization using Z codes, and how's it going?
Okay, so we are using Z codes in two ways. We're using it for data collection and reporting. And with that, we hope to look for additional avenues of funding for our patients and new programs we could potentially offer our patients. We're also looking at individual levels. Our providers are addressing them with their patients and tracking them throughout their healthcare visits and seeing how they can help advocate for their patients and help those patients decrease those barriers and what other issues those barriers may be causing, where they can't get to their referrals or pick up their prescriptions, and how as a clinic, we could help them with those. Okay, Julia.
Yeah, thanks. And thanks so much for having me here. It's really a pleasure to be here with all of you today to talk about what's, really one of these big, important emerging issues in our field that at the AHA we're really we've been focusing on over the past few years and are going to continue in the future. So I think it might help to do a little bit of level setting because, Katie comes from a clinic, and at her clinic they actually use the Z codes, but I'm from a hospital association. So while we don't provide care, the AHA is the trade association that represents our nation's hospitals and healthcare systems. And as our association's vision is a society of healthy communities where all individuals reach their highest potential for health. And to achieve that vision, our organization has two arms that really complement each other. So on the one hand, we have advocacy and representation. Those are the folks who are in DC, and they make sure that hospitals' perspectives and needs are heard and addressed in health policy development. And on the other hand, where I'm based in Chicago and really where I sit in the organization, member assistance. And over there, we provide technical support for healthcare leaders and hospitals on emerging healthcare issues and trends. And over the past year and a half, obviously, a lot of our attention has been on the COVID-19 pandemic and how to provide relief and recovery for our hospitals. We've also really been focused on issues like behavioral health, workforce needs, and health equity and value. And so this work that we're doing on value, why I'm here today is because Z codes really tie together what we're seeing on health equity and value. And just a little bit more level setting. This might be redundant for a lot of you, but this is my little soapbox. And every time I talk to an audience, whether it's you guys or my friends and family, I feel the need to get up on my soapbox and say this: health is more than just health care. We know that there's this growing body of research that shows that only 20% of health comes from healthcare. And the remaining 80% of that are the societal factors that influence health. So that's the air we breathe, the homes we live in, education we receive, the jobs we have. And these are the things that are reflected in the Z codes. And these are the issues that in turn lead to health equity. And so I think over the past year and a half, the pandemic has really helped people understand the importance of health equity and what it looks like when there are health inequities. I think this story is important to tell over and over again, that health is more than health care. So Alan just gave you a great overview of what Z codes are. So I want to dive in a little bit to why we at the AHA think Z codes are so important, because at their base level, they're really just billing codes, and they're not generally currently considered for payment. But we know that people's social needs are health status influencers and are thus really important, especially as we look towards the future and this move towards value-based care. So I'm going to offer you 4 reasons that Z codes are really important. One, and Katie, I'd love to hear what you think about this when I'm done, since you're in the provider setting. For one, it helps providers provide better care. So to treat someone as a whole person and not just a patient, it's really important to understand what happens outside the walls of that hospital or clinic. So screening for social needs and then linking those social needs to Z codes help us understand how to better meet people's medical and social needs. 2, having this data allows hospitals to identify population health trends in the community. Because Z codes standardize the social needs data in a way that we don't generally have, hospitals can do their data analysis and they can use the data to align services and programs to meet the needs of their patients and make sure they have the right healthcare teams and community partners in place to address these issues. So for example, if a hospital's care teams are consistently documenting food insecurity and noting that in the Z codes, the hospitals can look at these data and use it as a basis to work with other stakeholders in the community to develop programs that are focused on increasing access to food for the communities they serve. So number 3, and I think this takes it out of the direct care level, and this is more thinking systemically about why they're important. So adding Z codes to hospital claims enables system-wide research. So we're not just looking at each hospital healthcare system clinic. We can look at the entire country or a community to get a better understanding of what the social needs of those people are, and then tailor federal programs to meet those needs. And then last but not least, and this gets to the point of payment and this shift that we're seeing from paying for healthcare just by volume to value. So connecting Z codes to claims can really help us at the AHA support policy and payment reforms that will include appropriate risk adjustments for social needs, enable hospitals to do even more work in this space for their patients and communities. So right now, the AHA advocates for quality measures to include socio-demographic adjustments where appropriate, and having more of these Z codes, social needs data, would further our argument and allow us to advocate that it be included in other CMS programs and measures and really start to integrate medical and social care more than we've been able to do to date.
Thank you. Wonderful. So sort of leading into my next question, you know, from an economics perspective, we think about a lot of these issues have historically been treated as externalities to the healthcare system. So we've long been aware that these social determinants are out there in the environment. They affect a person's journey from a healthcare perspective, but it's for the large part, a lot of that has been handled outside or considered to be a problem that sits outside the four walls of the clinic. The Z code, in my mind, is really an explicit way of internalizing those issues by giving them a diagnosis code. Now, it sounds kind of wonky and medicalized, but to be honest, that's kind of necessary if you really want to start to pull these things into the hospital and clinical setting. You've got to, you know, put it into the framework and the infrastructure in which those settings operate. So I've heard this critiqued as over medicalizing these problems, but you know, this is a way to bring those in. And of course, if you have once you have a diagnostic code, you know, and there's a chicken or an egg thing as well here, but generally speaking, it means you're going to start having some sort of screening or assessment to determine a threshold for diagnosis. And then people have already started asking this in the Q&A, so I'll kind of address it here. But then, you know, the idea would be eventually, and some people have noted that there is already some connection to this and reimbursement in certain of the Z codes. But the idea would probably be that at some point you would have CPT codes or other sort of reimbursement codes, or these would be built into payment, you know, sort of quality payment initiatives as well, value-based payment initiatives. So that's kind of the big picture. But before we get too far ahead of ourselves, could both of you sort of on that topic of how does this work in the healthcare setting? So maybe if you could address, you know, how widely are these used in the practice setting? You know, in your particular experience, I know, Katie, you guys are using this. Maybe talk a little bit about what it means, you know, in your clinic, how they're applied and how they're used, and what will it take to increase adoption of these Z codes?
So originally we started out with just our community outreach worker doing the screenings, and we have transitioned that over to our MA team. And so now they do a social determinants or prepare screening for every new patient, every patient seeking an annual or a hospital follow-up. And with those, they then use the prepare tool to break down at it over a broad level, and then they break it down based on what the patient answers off that tool, instead of asking all the questions in the social determinants of health, to put less burden on the team and the patient, since they already have so many other screenings. And I think a way we can expand is definitely involving more of our teams to do it besides just our medical team. Right now, it's just our medical assistants asking, and then they reach out to the provider so that the provider knows what the patient answered and put them in touch with either our community outreach and enrollment navigator, or depending on the Z code, the counselors or outside counselors that we can offer them. There are some programs that our MAs are very aware of in our community that they can put them in touch with the patients themselves. And it would be nice to see our acupuncture team start to adopt this as well. But right now we're just piloting it with our MA team.
That's great. And then, you know, at a national level, I think adoption of Z codes has not been as high as we'd like it to be. We've started doing some research, and, you know, I was talking to some colleagues in Indiana who have been tracking this. And in 2020, about 0.69% of their claims statewide included a Z code. So that's not very many. and you know, we at the AHA, we've been trying to understand, you know, like what's holding us back from doing these more often, and have come up with a few of the main barriers that I think help us think through how to increase adoption. So one is, of course, lack of definitions for the terms, both for providers and coders. Like Alan, as you were saying before, like integrating social needs and all these non-medical factors into care is still fairly new for a lot of our providers. So they're not particularly comfortable noting that someone has a social need unless they've gone through like a screening process. It's also a new thing for coders. Like they have very specific codes that they're looking for. And these social needs codes are a little bit new. There are also some operational processes that have been challenging. So making that transition from screening to coding, who's documenting it? Is it standardized? Is it in the medical record in a way that a coder would know where to look for and be able to code it? And Katie, you shed light on this a little bit, but there's when these first started, there was a lack of clarity about who can screen and document social needs. So when Z codes were first released in 2017 or 2018, I don't remember which year exactly, it said only physicians could do that. But my colleagues in the coding clinic at the AHA lobbied hard to get that changed. So now it can be any healthcare provider, whether it's a nurse or social worker, community health worker, et cetera. So that really opens the doors to who can help with this. There's also, and I think this is going to be one of our biggest issues going forward, is that there's a perceived lack of priority that this is an important code because there's not yet a financial incentive in most situations. Because, you know, a lot of commercial and government payers are starting to bat around the idea of like, how can we pay for social needs and like, how can this factor into the risk adjustment? But that's not across the board. And as a result, hospital leaders aren't saying that this is a priority code. So it often gets skipped on the priority list, which then leads to productivity challenge. And coders have productivity goals that they need to reach, and they need to get through a certain number of medical records, and they can only use a certain number of codes per record. So if the Z code is not for social needs is not a priority code, it might just get skipped over. So I think we're in this really interesting place where we're seeing a lot more hospitals, health systems, clinics screening for social needs. So like we know that the data is there, like the Prepare tool is everywhere now. It's integrated into the EHR, but like how do we take the data that's there and actually get it into a Z code? So that's why we're doing a lot of educating and talking to as many people as we can so that we can get people thinking about this and making it a priority as we look into coding in the future.
Thank you. So one question that was proposed that I already answered in the Q&A was about the granularity of these Z codes, and I think I blew right through a slide where I actually had planned to illustrate that. But there's the 10 Z codes are approved at that high level. There are proposals, and that's what some of those proposals were at the recent certification. You know, the maintenance certification committee was to actually delineate those high-level Z codes to further granularity. So I put some in the Q&A around Z59 explicitly, and you get down to Z59.41, which would be lack of adequate food, 0.42, food insecurity, 0.43, lack of safe drinking water. So that the idea is that, you know, you would be able to get more specificity about the nature of the issue beyond just that high-level Z code. So they are high-level and vague, just like cancer has a high-level Z code, and then you start breaking it down. You get down to the point, you get down to the thousands or even lower for certain diseases in the ICD framework. So, but coming back to the issue about how to do this in the practice setting, you know, and I'll tie this back to a question that's in the chat as well, is you know, there seems to be a gap between screening and documenting social needs and actually using the Z codes. So like you said, the Prepare code is everywhere. And maybe you kind of alluded to this a little bit, Julia, so I'm sorry if this makes you repeat something you've already talked about. But there's a gap between screening and documenting those social needs and using the Z codes. And why is that? What can be done about it? And then thinking about whether you're screening for the purpose of a Z code or not, there is, and this speaks to the question here about, well, how do you, how does that deal with sort of privacy and confidentiality concerns? I mean, how do patients react to this when you start screening for these things, when you start or if they see, obviously, if you're diagnosing somebody with something that's on their record, so now they have a diagnosis code, I assume that at some point could be visible to the patient, and now they see they've been diagnosed with food insecurity. So maybe talk a little bit about that privacy and confidentiality concerns, as well as, with a gap between screening and documenting social needs using tools like Prepare and other things, and then actually using the Z codes. Julie, why don't we start with you? Or Katie, if you, either one, just jump in. Katie, you started, so I'll start with you.
Okay, so when we started the implementation of Z codes, we brought in our patient advisory council, and we definitely did see with taking this to the council that they had a lot of those concerns. So what we do is when we do the screenings, we ask them if they're okay with these living in their charts. And I mean, most patients we found seem to be, but there still are some that are hesitant. They feel like they're okay with their current PCP knowing, but if we refer them out and that diagnosis code goes on with a referral, that provider we referred them to is going to treat them differently. And that's their biggest concern that we have had. And then there were some privacy concerns around the Z code specifically with involving patient safety. And so we're hoping as these become more familiar that we see a lot more hesitancy for patients wanting them in their charts, and it does become more standard. But because it's so new, we do have some patients that are very concerned about these living in their charts.
Now, Katie, just a quick follow-up. Are you guys using codes or beyond just the high-level ones, or are you just using the 10 high-level that have been approved and in the ICD-10 code?
So we're just using the 10 of the higher level for right now until our team gets more comfortable using them, and then we will start to eventually break those down.
Yeah, there's nothing correct that stops somebody from using your own system and being more granular, but they're not. The ICD-10 code formally only recognizes those 10 broad categories at this point. Julie, go ahead. And maybe, Julie, while you're answering, could you also work into your answer, is there a crosswalk between the Prepare screening and the Z code? Do those connect?
Yeah. So I think that crosswalk is really getting buy-in from a few levels of people that really need to be supporting this consistently across a system. So it has to come from the top down. You have to get hospital leaders talking about it, talking about how equity and social determinants are important to the system, and that like everybody has a role to play in this. It's not just the doctors, it's not just the community health workers, it's everybody from senior leadership down to the coders. So getting hospital leaders on board, huge. Number two, and I think this connects to kind of to the piece about how patients react, but it's also providers. You need the providers to consistently be screening and documenting social needs. And that often involves a sensitive conversation with patients that we've heard our providers just aren't inherently comfortable with. I remember talking about like social determinants of health data years ago, and someone in the audience raised their hand, like, we really want to be doing this, but no one is comfortable asking patients, like when they come in about like their food insecurity status or if their home is safe. So like help us have these conversations. So we have a tool to do that, but it really takes some training on the provider side to have these sensitive conversations with people and make sure that they feel comfortable sharing this with their provider and having it documented in their medical record. And Katie, to what you were talking about before and how patients react, I think it was the folks at Siren a couple of years ago did a study, or maybe it wasn't them, I don't remember who did the study, about like the acceptability of social needs screening, and if this is something that patients wanted. And it came back overwhelmingly that like, yes, people felt seen and heard when their providers asked them about what was going on in their lives outside of the clinic. Because, a person is only a patient for a few minutes when they're in that space, and the rest of their life is outside of that. So, having someone who can see you in the context of your life, hugely valued by patients. And so, yeah, there's definitely that tension between, privacy and confidentiality and like being open to the conversations. But I think if we are training our providers to come into those conversations and build trust in those relationships, that goes a long way. And And that third level of people that we need buy-in for are the coders and the coding managers. They need education about these new codes, and they need encouragement to use them. So if we get our leaders, our providers, and our coders all prioritizing this and on the same page, I think we can make progress in increasing adoption.
So a quick follow-up question
Yeah.
on that point for both of you. And this is a question in the chat that's related here in the QA, so I'll go ahead and put it in here now. Julie, you mentioned providers, and I'm sure you're meaning, that's physicians, it's other individuals that may do this.
Physicians, nurses, social workers,
Yeah.
whoever is interacting with the patient.
Yeah. So, Katie, remind people how you're you mentioned it at the beginning, but I'm not sure everybody caught it now that we're a little deeper into what this means and how it's being operationalized. Talk a little bit about, who does the asking and, to the extent that it is physicians or it was, did they, what's the sense of obligation to treat, right? So, we're not there yet, right? So that's sort of the baby stepping, right? Is you screen, you diagnose, you treat, but we're not quite there yet with the treatment, certainly not the payment for it. So talk a little bit about that, if you don't mind.
Yeah, so it is mainly with our team, our MAs and our nurses that are conducting the screenings. And then they will let the provider know what the patient screened positive for. And then the provider can address it during the office visit, and all of our providers are. They're also looking at it in additional visits when the patient comes back and they ask how they're doing with those needs. Since it's now living in our chart, they can see it. And so there's better follow-up from our care team that way, which has been great to see because our providers are definitely really engaged with making sure their patients get the follow-up for these needs. And then they also send messages to our community outreach worker and our counselors, depending on the Z code. We have it kind of broken up based on topic of which an MA could handle and give them the resources for what a community outreach worker will need to be involved and when to get a behavioral health counselor involved.
Thank you.
Yeah,
so a lot of, go ahead, Julie, add on to that. And then,
for just a second.
Yeah, go ahead.
Yeah, I mean, we've heard from providers for years, like they don't feel comfortable asking the question if they don't know what to do next. I think the field of referral, like online tools for referrals, has grown by leaps and bounds in the past few years with like Unite Us and NowPow and all these other like closed loop referral services that can connect a patient with community resources like at the point of care. So we're seeing that like downstream when patients present social needs, like there has been a lot of growth in like having a functional response when these needs arise. And like they might not be able to like fix someone's unstable housing situation, but can at least connect them with resources that could help.
So 2 more planned questions, and then like I said, I've been getting to some of the Q&A as we go, but there's some really good ones in there I want to leave to that section. Put on your fortune telling hat or your ability to tell the future, and where do you see Z codes going? What's the future here?
Do you want me to start with my little?
Yeah, go ahead. Yeah.
I don't know about Z codes per se, but over the past, 5 to 8 years, the prevalent or the understanding of social determinants of health has grown so immensely that like we don't have to explain this to everyone all the time. And I think that that's a huge step for our field. And the next step, like we recognize it as an issue, we recognize that it's real. The next step is, what we can do about it as a field. And unfortunately, like payment is necessarily a piece of that. There's definitely a lot more chatter from payers recently about how they can address patients' social needs, both the private payers and the government. So, I think that this will pick up steam and this isn't going anywhere. The question is going to be how quickly we move.
Yeah, I definitely can see it eventually becoming part of metrics for, since we're in FQHC, we do a lot of UDS metrics and federal metrics that we have to meet. And I can definitely see these becoming a part of those and reporting out on those for the state and federal level here. So.
Yeah, And I can see these being involved in risk adjustments much more than they have been so far, because, you know, these codes are not really diagnoses, they're influencers of health. So they can just help paint a more accurate picture of the complexity of the patient situation. So, you know, as we move forward with risk adjustments, it certainly helps.
See
Thank you.
more programs that'll help address these issues be implemented.
Yeah, and again, I would just refer people back to that CMS infographic to get some sense of at least where CMS thinks this could go, you know, from a hospital, at least a hospital perspective. And there's lots of great questions in there about what about the community, et cetera. And we'll get to that here in just a second. Last question for you guys. You know, how were if and how were different groups involved in the development and implementation of your organization's approach to Z codes? I think that's more a question for you, Katie, because Julia, obviously, unless there's something in your background I'm not aware of, you haven't, you know, implemented this at the site level. So Katie, I think this is a question for you. And you alluded to it already, but maybe expand a little bit more on what that looked like.
Yeah, so when we started the pilot, which was August of 2020, we implemented, or we brought in our clinical team and we asked them when they'd like to do the screenings, when they think it would be most beneficial to do the screening, since they already had so many screenings. And we wanted to make sure they were involved in the process, because we felt like the more they were involved, the more they would care about the whole workflow and the process, and the easier it would get it adopted. And we definitely saw that they're very engaged with the workflow. We involved our patient advisory council on, so that way we could determine the approach to our patients, how we ask our patients when we're conducting the workflow, how we address the questions, and, you know, how we go about adding it to the chart. And what we found there was they wanted us to ask them if it's okay. So where now we're not documenting every Z code because some patients don't want it, at least we're capturing some of the data now. And then we also involve our CCO, which is assigned through Oregon Health Plan, and they took it to their community advisory council, which are all patients with Columbia Pacific Insurance, and asked how they felt about it on claims, gave them a sample, and we were able to work out a workflow with them and get patient and provider response. And so far we have had pretty good reviews from the patients. They're all very happy that we're doing the screenings. I don't think we've had one that has really posed an issue with the screenings.
So just to follow up, and this is a question in the Q&A. So I think you alluded to it, but just to be clear, you did mention something about some hesitancy about Z codes living in their charts. So either in the implementation of this and or during your vetting this with your patient advisory group, what kind of reasons did people, can you be more little, I mean, some are fairly obvious, but maybe give some examples of some of the reasons behind the hesitancy, either from your patient advisory group or from those that, you know, from the practical experience of implementing this in practice. And the idea, again, you mentioned, you know, some hesitancy around having those codes live in someone's charts. So talk a little bit more about that if you can.
Yeah, so some of our patients, their concern was that if we referred them to a provider outside of our organization and they saw those Z codes, that they would get treated differently, that they wouldn't be, their care wouldn't be prioritized in the same way. They wouldn't get the exact same level of care because they would be looked at as poor or not able to afford it. And that would definitely affect, they feel like that would really affect their healthcare and the quality that they would get. And so they are very hesitant about us putting that on to their charts to go to outside referrals. And then the other one was the Z codes more around patient safety. They're worried about those coming in on claims, and if they're having safety issues at home, their potential spouse may be seeing that if they open up the claim from insurance. Those ones tend to be less used. We refer them to behavioral health, but I don't think we drop the Z codes in the charts as much on those ones. And we definitely had more provider concerns on those ones. So.
Yeah.
And maybe Julia, from your end, and Katie, you can probably address this as well. I'm moving now explicitly into the Q&A here. So if you have questions that haven't put in the hopper yet, please feel free to do so. I'm going to start taking these, not necessarily in the order they came, but kind of somewhat. But on the same topic, how long do you, when you mention, is there any sense of how long it takes, or do you think there's tolerance for giving time in the clinical setting, whether certainly probably not the physician, but it could be, but other staff that are busy, nurses, social workers, etc. So Katie, what have you seen? How long does this take? And Julia, have you guys sort of thought about or done any testing or any thought to, where is the time? How do you create the time, and how much time does it take to do this right? I wouldn't expect you to know the answer, but just if you have any thoughts, I think that would be interesting to hear. Because we're all here all the time. There's just no more time to do anything else, and we all want to. Everybody is prioritizing and wanting to address social determinants and have a role in the clinical health system, at least trying to identify them. And using that as a basis for referral or linking them to resources. But talk a little bit about the time it takes to do so, and the resistance because of that time, perhaps. Julie, you want to go first, and then we'll.
Sure. I think in a lot of cases, the screening process happens virtually, and sometimes it's in your pre-visit, like screening information, you fill out some stuff. So it's not taking up time in the actual clinical visit unless there's a positive screen. And from the people we talk to, like, they see how these social needs are connected to patient care. And they recognize like they need to ask the questions in order to have the ability to like provide whole person care. So yeah, like time is an issue, but I think you're gonna spend more time trying to figure out what's going wrong if you don't understand the whole context of that person, and like this, like that initial online like self-report screen is just like a straightforward way to get that information without disrupting workflow too much.
Yeah, so our screenings we do at the very beginning of the visit. They don't take much time, especially using the Prepare tool if a patient screens negative. A lot of times if we're like very busy, we do ask the patient if it's okay for providers to reach out to them outside of the office visit, if in regards to those needs, to get them access to those organizations. So we'll ask them if we can have the outreach worker contact them at home via the phone, instead of trying to get the outreach worker in on the visit.
Yeah, and a thing I like to point out to some folks is for a lot of these issues and a lot of these patients, you're gonna end up spending time on it somewhere down the line, either explicitly or either because people aren't going to show up, or because when they do, these things are going to surface. So better to build in a system for dealing with it early and from the beginning, rather than waiting for it to take time up or lose time down the road. So thank you. So this one was asked early on, so I'll go ahead and broach it. It's a little bit of a change in topic, but it goes back to something you were referencing, Julia. How do you prioritize these codes? Like, so there's a coding here and there's an art to the coding. So, would we be able to increase the allowed number of codes for coders, for example? Is the explicit question. This goes a little over my head, maybe yours as well, but
it goes over my head as well. But like I think I said before, I think like it needs to come from hospital leadership and the coding managers. Saying like, if you see it, don't skip over it and keep going. Like, actually document it. And we might not be able to capture everything, but
I assume there'd be more priority given to the codes if the codes were tied to reimbursement, so that there is some of that. So someone actually gave an answer that they do get reimbursement for Z59, I believe, in their federal facility. And I think I think Katie, you referenced that sometimes the code can be used as a justification for the complexity, for billing for a more complex or higher level visit. So the code itself you don't get reimbursed for, but it's something you add to kind of justify a visit for which there may be higher reimbursement. But that obviously, if there's payment, that's going to increase priority for using the codes. But there's not
Absolutely.
now, and the codes are seeing some uptake.
Right.
already.
It's like this catch-22 where like you use the codes that get reimbursed for, but also we want to start using the code so we can better make the case for reimbursement. And like, where do you start? I think we should start.
Yeah, talk a little bit about screening out in the community. So could you do this? And I assume this is kind of there's a couple different ideas here, but Katie, have you guys taken this approach rather than doing it, waiting for people to come to the hospital? Is there any plans? And Julia, from an age, are you guys recommending, or have you heard of any groups that are not just waiting to do these for patients as they come in, but doing some of this out in the community? That's a lot to ask, I know.
I'm trying to think about.
It's
like,
okay if the answer is no. I get where the question's coming from, but
I do too, and I'm trying to think about like the ethics of doing that, and like
yeah.
I can imagine knocking on someone's door, being like,
I can imagine community group,
Like an outreach event, maybe.
well,
yeah, if it was like a health fair or something like that, and that's part of the.
Well, we do have a food box program where we don't just service our patients, but community. We may be doing it there.
Yeah.
Mm-hmm.
Well, part of the reason we brought this subject to this group is because I think there is the potential, it's not just hospitals could use these codes, right? Community group, and then the screening, right, that's associated with them. So there certainly could be community organizations and even nonprofits that use these tools, the screening tools and the codes. We do some of this ourselves already as an organization. We have our own taxonomy and nomenclature for how we code things, but it lines up pretty well with the Z code. So we're going to start reporting out some of the issues we see frequently against those Z codes, not because for no other reason, just because it's a common way to start talking across sites. So I do think that there is something to be said about, community organizations and national organizations coming to some agreement about what's the right tools to use to screen, what are the right thresholds and cut points for determining a threshold sufficient to say diagnosis. So that's not where we are, but just to plant that seed into some of the audience members' head, that's part of the reason we brought this to everyone's attention, because this is something that could start to create a common framework for community organizations, national nonprofits, social others to kind of be on the same playing field and speaking the same language as it relates to screening, diagnosis, referrals, etc. So anything you want to add, Julia or Katie, to that?
Yeah, your last question to Katie about how to like engage patients and community members in the Z code process. I think the part where they could be most instrumental is really in like the screening approach. Mm-hmm. Coming together, especially when we're talking with patients who might be from historically marginalized populations or experiencing health disparities, like really hearing their voice on like what they want to be asked, how they want to be asked, in what settings. Like the Z codes, that's just like a billing process, but like the real human component of it is that screening and how we talk to our patients about their non-medical social needs. And I think that's a really rich opportunity for connecting with patients and communities and understanding their perspectives.
Thank you. So, Katie, I hope you don't mind. We keep picking on you a little bit here, but there's a question here, and I'll maybe ask it, but add a little bit to it. For the most part, these are issues that we know clinics and hospital systems are not planning to address themselves. There's some of these issues that could, around, inability to afford healthcare, right? So hospitals do tap into themselves, copay assistance, financial aid, et cetera. But a lot of these are going to be more referring out, right, to community resources. So and we don't really have the infrastructure to do that. Some of that's already happening, right? So these things do surface, and that, the social worker, the financial navigator, the nurse, the PA, somebody does that sometimes in certain circumstances. Are you, for Katie, I know you guys are doing this. How are you preparing the staff to make those referrals? Do you guys go out and sort of have where all the places are you could refer to? Do you have like an inventory? Talk a little bit about how do you operationalize that referral process?
Yeah, so we have
Particularly around things like food and housing is the specific question here.
Right, so we have a list of community partners in Tillamook County that for our providers to see, so they can do it right then and there. And then we also, with our outreach and enrollment navigators, you can look for areas, if it's not Tillamook County, where we can send patients or potentially partner with to get them to come out and help our patients.
Those resource directories become a key part of this, right? So we have one that we build and operate and make available to the public, but I also know at the local level, those become pretty important. So that's another place where I think community groups and patient groups can help sort of fill in and help build those resource directories based on what's available for certain types of issues in the community and beyond.
And I know it differs everywhere, but 211 can be a fantastic resource because they're keeping the inventory up to date themselves and can refer people to all sorts of different resources. So I know like in San Diego, they have a particularly robust 211 that is connected with a lot of the healthcare systems. So they can do like closed loop referrals and make sure that they're connected with the care managers. And I know not every community has that, but there's just some like very cool examples popping up around the country where you don't have to just, have a manual like list of all your community partners, but there are like electronic dynamic services to help facilitate that.
Yeah, we have Unitas rolling out in our community. We're waiting until we get more community members involved in Unitas, and we plan on using that platform for our providers. And then that way it's easier to close the loop on those.
Awesome.
Yeah, and Cindy raised a good point that we focused a lot here on the clinic and the hospital level, but this is happening a lot in the pharmacy space, the retail pharmacy space, the specialty pharmacy space. Obviously, if you've got community health workers, that's another connection point that could be tapped into. So I'm aware of a lot of things that the pharmacies are doing now, very similarly, using using a social determinant screener, the Prepare tool, or one they've made themselves, or some combination thereof. And I don't know that they're using the Z codes necessarily, but I know that's why I pointed out the Kaiser one, and United Healthcare was the one that came to the maintenance committee with the proposal. The health plans are very interested in this and are using it as well, in addition to the pharmacies and in their outreach around social determinants. So just something to keep in mind for those that are still with us.
Yeah, I know.
Go ahead.
I know our pharmacy, since they're on site, they have access to the same data we have on our patients, and they can go in and see what needs our patients are facing and help them with their medication costs that way. And that they've been doing that since we rolled out the social determinants of health screenings and the Z code process.
Wow. So Katie, there's the last question in here, and it's for you. So I'll just see if you have an answer here, but you're working with Oregon CCOs on Z code reporting. Have you seen signs of how the CCO is utilizing the data for patient benefit?
So they haven't implemented anything yet. They're working on posting it for funding and to get more payment for the clinics. So like we have certain metrics that we get reimbursed for meeting or getting close to meeting based out of a bucket. And so where we might not get paid out on the claim for the Z code, we could get paid at the population level for doing the screenings. And they're looking at implementing things with that. It just has to go through the state, and it's still in that process. That was a whole part of our pilot, was to work on implementing the Z codes, getting them tracked by the CCO, and then so they could have the data to go to their leadership and push for the funding.
Thank you. So last question for both of you, then we'll kind of wrap this up. So I'll ask a specific question. You're welcome to touch briefly on anything you feel like we didn't talk about or you want to leave in people's heads. But I guess my main question is, do you feel like this is serious enough that patient advocacy groups should really be starting to pay attention and thinking about how they may get involved in the shaping of this as well as the implementation of it? Is this serious? Is it real? Is it here to stay potentially?
I'm going to go with yes, real, important, and here to stay. And I'm realizing in my answer before, I was talking about how important it was to have hospital leaders and providers and coders on board, but it's really important to have patients and advocacy groups talking about this too, so that we're coming at it from the top and we're coming at it from the grassroots. And hopefully we meet in the middle and make this a really important, sustainable thing so that, you know, our healthcare system of the future is one that can tackle both medical needs and social needs and just, you know, try to help our patients and societies thrive.
Right, yeah, I definitely think it's very important for these groups to be involved. That way they can have, because there's some things like we never thought or would have thought about when implementing the process had we not involved our patient advisory council. And the last thing we want to do is alienate any of our patients or make them feel any different than the others. And so we want to take that approach and use a trauma-informed care lens. And I think it's really important to have patient group feedback on those.
Well, thank you. Thank you to both of you, Katie and Julia, for taking time and letting us grill you with questions and offering your insights on this topic. I do know we have one closing slide. I don't know if Jen or Caroline want to put that up. But while that's happening, just in summary, I will say, you know, there's a lot that we left on the table here. And so we purposely tried to just focus on the Z code and some sort of practical sense of it to give people an introduction to it. But if you're putting your patient advocacy hat on, you know, for those of you on the call who are patient advocates and with patient advocacy groups, think about this, the way you know, how do you screen for these things appropriately? And, you know, these screening tools are often built elsewhere, but it's ultimately the patient is the one being exposed to and answering the questions. So that's one way of thinking or getting involved. The cut points, you know, how do you establish what's the right cut point to be diagnosed with any of these issues? How these things are expressed to the patients when they start to say, hey, you've been diagnosed with these things. Some of them could get pretty personal. I've seen some proposed Z codes that even talk about potentially diagnosing someone with having bad parents, you know, which is true. That may be true, but how do you diagnose somebody with that? And that's not a Z code now. I've just seen that as a proposed sub Z code, just to give some example to this. So there's some sensitivity to how these things might be phrased better in a more patient-friendly way. And then, of course, ultimately, there's once you diagnose and, you know, screen and diagnose, you have an obligation to treat. So how do you, and obviously a lot of community groups and patient groups are going to be part of that mix of being the handoff, right? Or receiving those patients in a referral type of situation, or getting a list of places you can go call. Hey, go call these groups because they help you with those things. So I that's not a question for any of you. That's just a reason for patient groups to, I think seriously about this and get involved with it, because if you're not plugged into it already, you should and could be part of the conversation at a number of different levels around the the screening, the treating, the diagnosis of these issues and how that's being operationalized within the clinical system, because it's going to reach out and the tentacles are going to be reach into your patient populations and even your programs and resources. So, which is a great thing, but something we need to think about. So I'm going to wrap up here. We're right on time. I want to thank the forum for hosting this, and we will post the slides for people to download. Is there any other next steps that I'm missing? There we go. There's keeps disappearing on me. There it is. So for more resources on the subject, here's the link to a website, and the webinar recorder will be emailed to everybody registered to attend. And again, thank you to Katie and Julia. Really appreciate it. Thank you for everybody who participated and sent questions and who listened in on the session. Thank you very much.